Good afternoon, everyone, and thank you all for being here. It's really amazing to see such a good turnout. So my name is Dimitra Rapana. I am an oncologist at St. George's Hospital, and I am delighted to welcome you to our report launch to hear about the experiences of people being screened for Lynch syndrome. Next slide, please. So this is the agenda for today. So I will make a very brief introduction on the Lynch project in the Southeast region. And then I will hand over to Nikki Scott, who is our communications and involvement lead in the Southeast GMSA, to discuss the approach we took. Then we will hear from Poppy Cohen and Serena Shaw, our communication and involvement support managers, about the project we did and the methods we used. We will continue with Emma Jenkins, our Lynch syndrome patient representative, that she will discuss the results of the survey. And then we will hand over to Stephanie Bell from the Cancer Alliance, and she will tell us how she's planning to use these results. And hopefully we'll have some time for questions. So there is a Q&A section, so please type your questions. And we will have also an evaluation at the end. It will be a QR code, so please do fill that in. So we're ready to start. So next slide, please. So we're going to discuss our patient experience survey report, and I just want to introduce the team that has worked on this. So myself and Adam Shaw, who is a consultant geneticist at Guy's and St. Thomas's Hospital, are the two clinical leads. Ella Limbu is our regional Lynch nurse. Katie Barber is our project manager, and Emma Jenkins, that you will meet later, is our Lynch patient representative. Next slide, please. So I thought I should just explain what the GMSA is, because not everyone may be familiar. So in England, we have 7 regions, and in each region there is a laboratory that will do all the genetic testing. And then the role of the GMSA is to ensure that that testing is being delivered and that we support the local teams so everyone has access to genomic testing. Next, please. And this is the area we cover. So, sorry, just go to the previous, please. So this is the area we cover, which is Southeast London, Kent and Medway, Surrey and Sussex, and a part of Southwest London. Next, please. So a very brief introduction to Lynch syndrome, which is a common inherited genetic condition and increases the risk of certain types of cancer. The 2 most common types of cancer are colorectal or bowel and endometrial or cancer of the womb. And Lynch syndrome is responsible for about 3% of all cases of colorectal and endometrial cancer. Now, Lynch syndrome is common. So we have estimated that about 1 in 400 people in the UK have Lynch syndrome, but they're not aware, and largely is undiagnosed. So the vast majority of people do not know that they have the condition. Next slide, please. And it's really important to know that you have Lynch syndrome, because then it changes the management and it can give you access to what we call risk reducing intervention. So as we said, bowel cancer is common, so people will be offered very regular colonoscopies, that is the camera test to check the bowel. They may be offered aspirin, that we know there is evidence that can reduce the risk of cancer, or prophylactic surgery. So women, for example, that have a high risk of cancer of their uterus may be offered a hysterectomy, so surgery to remove their uterus. And of course, I treat bowel cancer. It's very important for me to know if someone has Lynch syndrome, because the treatment that we will offer them is very different. Next slide, please. So it all started in 2018 when the charity Bowel Cancer UK highlighted these findings that very few hospitals across the UK were actually testing people with bowel cancer for Lynch syndrome. And this is how the national transformation project started. And essentially, the aim was to ensure that every patient with colorectal endometrial cancer was screened for Lynch syndrome. Next slide, please. And another issue that we realized was that the wait to get tested for Lynch syndrome was very long. So here we're showing the waiting time for years 2019 to 2021. And it took about 10 months for people to get tested for Lynch syndrome. And of course, that is not how it should be. We really wanted to reduce this waiting time. And the reason it would take such a long time is because these patients would be referred to genetic services, and genetic services are tertiary services that are small and also, unfortunately, have very long waiting times. Next slide, please. So what was suggested is to adopt mainstreaming, and essentially what that means is that Lynch testing, instead of waiting to be referred to the specialist genetic service, that testing takes place in your local hospital with your bowel cancer team or your gynecological team, and of course genetics would support all the results that came out from the testing. So mainstreaming essentially means that we reduce that waiting time to get that testing done. Next slide, please. And in the Southeast region, we have been working on these 5 work streams. So very briefly, trying to make sure that we improve the pathway, we support the local streams to test locally. We have built business cases highlighting the benefits from all this approach, so we can hopefully convince the commissioners that this is something that it's worth investing in. We have built an expert network, bringing experts from the region together to discuss advancements, to discuss research and projects. And also we're working on some additional things like the bowel cancer screening uptake. Next slide, please. So very briefly, I'm going to just present some of our successes. So in the region, 96.7% of all endometrial and colorectal cancers are currently screened for Lynch syndrome. And in that multicolor graph here, you can see that the genetic testing also keeps increasing year after year. And very importantly, there are more colors in each of these bars. And that means that the testing doesn't only happen in the 2 genetic services, which is the blue and the yellow, but local hospitals have also are also doing the testing. Next slide, please. And we have already seen an improvement. So the time from cancer diagnosis to Lynch syndrome diagnosis is reduced by 48%. Since this work started. So we're hoping that with more hospitals mainstreaming, this will be even better. Next slide, please. And of course, we have done all this. We have seen that the testing has increased, that and also it takes less time, but we really wanted to hear about the patient's experience. So you're going to hear how we did this survey and how we're going to use that. But the main aim is to try to understand what the patients are asking, so we can try to adjust our services accordingly. Next slide, please. So I just want to highlight before I hand over to Nikki that this has been a collaborative work, including charities and many services in the NHS. And we're all really, really proud to be part of this because it has been a really successful program. So I'm going to hand over now to Nikki to discuss the approach we took.
Thanks, Dimitra. And we're going to go into some more detail. But first of all, I just wanted to set out, for those of you, I know some of you are here today because you're keen to learn how we did it, and so that you can maybe think about how you might do things yourself. So we really very, very passionately didn't want this to feel like a typical NHS survey. The NHS but has to do lots of surveys, and we are bombarded with them all the time. And we know as patients that you continually get service from the NHS. So we really wanted to create something that felt different, and we worked very hard on that, which is why we're taking the time to share that bit today. And I'm going to talk to you about our ingredients for success, but we But firstly, it was very important to us that we co-designed our approach with people who had been screened for Lynch. And you're going to hear from Emma today, who's been absolutely instrumental in our approach. But we also talked to lots of other people as well who had Lynch. But also we worked with a great group of clinicians, and that's definitely one of the secrets to the success. So Steph, who again is going to talk to you, she's from the Surrey and Sussex Cancer Alliance, but many of the cancer alliances helped us in developing our approach and kind of cross-checking our thoughts as we went along. So we really couldn't have done it without Emma or our group of clinicians and professionals that work with us. We strived really hard to create a safe environment to enable people to have very honest conversations with us. And that safety is through every part of our approach. So we worked very hard on our tone, the language we used, and all of the connections we made with people. And that brings me on to my next point, which is it was very important. Sorry, not go back a slide, Casey. It was very important that we built personal connections. So we were very much we used our own names, we didn't use kind of generic inboxes, and we made personal connections. So once one of us spoke to a patient, that person dealt with that patient from then on. And as I've mentioned, Emma and others were involved throughout. So next slide, Katie. Thank you. So these are our ingredients that what we think has made a successful project. As I said, Emma has had an absolutely equal voice. We haven't treated her any differently. She has been at every single meeting. She's been part of every single conversation. She has done as many, if not more, tasks than the rest of us. So she has absolutely been an equal voice. And I mean, that has been very important to us. It's not a tick box at all. We had a great group of people that really worked with us to help spread the word. We didn't do this in isolation. Many of you are here today that helps us to connect and spread our net much wider, and that was really important to us. So we didn't operate in our own little bubble. We didn't use a sniff of NHS or corporate wording. Everything we put out was in real language. Many of you will know that the average reading age in England is age 11, so everything was pitched to that right kind of tone. We used really compelling imagery. We all know we're scanning things all the time, so we created imagery that would cut through the noise, would look a bit different, feel a bit different, would grab people's attention. The warm and friendly tone I've mentioned, and we talked to people. I know it doesn't sound like rocket science, but that is really important. A faceless online survey is not engagement. That's not how you truly engage with people. And that was really central to our approach. So we talked to people, we talked to them as human to human. And I know that doesn't sound very clever, but actually that is the nub of the success. And we were really proactive. We built connections beyond the usual voices. So a survey will pick up lots of people, but it will tend to pick people that are motivated by a negative experience, or you'll hear the traditional voices that you always heard. We strived really hard to go beyond those usual voices and hear from different people. And as I mentioned already, we made personal connections. So we didn't have generic inboxes. We had a very human approach. So I'm very happy to take questions in the chat on those, but those are what we believe were the ingredients for our success. But I'm going to hand over to Poppy and Serena because they're going to talk to you about how we did it, the actual nuts and bolts. Thank you, ladies.
Thank you, Nikki. And yeah, so I'm going to talk a little bit about the distribution. And I think that it really builds on what Nikki was saying, that we wanted to hear from as many people as possible and as many different people as possible. So we made sure that the eligibility criteria was as broad as we could possibly have it. So the only people who were excluded were those who hadn't been tested or those who were tested outside of England. And then in terms of how we actually distributed the survey, so the methods were varied to get as many different people as possible. So we had direct patient outreach via our fabulous clinical colleagues. We shared with charities that we had spoken to before, but also kind of cold emailing ones that we hadn't, so that they could share with their members. So for example, we had Bowel Cancer UK and Cancer Research UK both share on their patient involvement sites. And this was really important because it meant that patients were hearing it from not just from us, but from sources that they were familiar with and that they trusted, and felt comfortable sharing. And I think that we also shared, on our social media channels, and Emma kindly shared as well. And I think that we hoped that this would encourage people to kind of feel comfortable to share in the survey and also be on the survey. And at the end of the survey, we gave people the opportunity to leave contact details for further interviews, which Serena is going to talk about next.
Hi everyone. Yeah, so as part of the survey at the end, patients were invited to take part in further one-to-one conversations about their experience, and collectively we spoke to over 20 people, mainly via Teams or on the phone. And together we developed a conversation framework to kind of guide the conversations. We began with closed questions to kind of help participants feel comfortable, and then we progressed on to more open-ended questions to encourage patients to share what was most important to them and ensuring that their thoughts shape the conversations. And we, as Nikki said, we'd really tried to create a safe environment throughout, so patients felt comfortable sharing their experiences with us. And we also had support available on hand from our Lynch syndrome specialist nurse if patients wanted to speak to her. And myself personally, I found these conversations to be really insightful, and it was a real privilege to be involved with these and hear about patients' journeys throughout the service. And also the suggestions that patients had were really impactful and help us kind of guide our report going forward. So following gathering this insight from the survey responses and interviews, we identified 6 key themes that describe patients' experiences and perspectives, which Emma is going to go into in further depth in the next section.
Thank you so much. It's fantastic to be here, and thank you so much for inviting me to be part of this. It is a really important part of the work, and I think that from a patient perspective, the GMSA's engagement with patients is something to be highly commended, because it gives me great hope for the future, knowing that people who are accessing the service are actually benefiting from having a contribution, so that they feel that they are much more than the part of the process and involved in what's happening in terms of their care. So we are here, well, as a group of people, but I'm here to talk to you this afternoon about what we did hear from patients regarding the survey questions that were asked. And as Poppy and Serena shared, they discovered 6 clear themes, and that's what I'm going to share with you today. So next slide, please, Katie. Oh, I feel like Chris Whitty. So these are the 6 themes that came out. They're not in the same order I'm going to be talking about, but that's just to keep you on your toes. And don't worry, the slides will be shared after this session, but also it's another way to encourage you to read the report once that link is shared with you. Next slide, please, Katie. So we're going to look at each section and talk about the information that we gathered from patients, but also think about some of the recommendations that the GMSA are going to be working with through their plan to develop and support people with over the coming weeks, months and years. So in terms of lack of integrated care, patients' experiences with primary care show that there is a real clear need for improvement. So concerns were raised with regard to the lack of integration between GPs, hospitals, cancer and even genetic services. So some people articulated concerns with regard to being belittled or fobbed off by their GPs. And again, that ordinary everyday language is so important. And those feelings, and I would appreciate this as a patient, can leave you feeling incredibly frustrated, because you don't necessarily know where to go if you're not being supported at that first point of contact. And some patients were even saying during the process that they felt that they were being written off for things such as their age, possibly their gender, and for some of them that they were being labelled or deemed as being a potentially anxious patient, so their concerns weren't necessarily being listened to. Also, some patients said that they felt they weren't being listened to when they were sharing that really important, vital family history, and many attributed this lack of knowledge and education around possibly education and training opportunities for those primary care providers. And we know that primary care providers have a huge job to do, but this element in terms of upskilling people to understand what Lynch syndrome is, the impact that Lynch has on patients, families, could also improve that process when moving through that healthcare system. And another source of frustration for recipients of the survey said that Examples were missing information or waiting long times for dates to hear about meetings, and that potentially records are being lost between services. Some were saying that there's a lack of communication, but others were saying that's a stark contrast to the experience that they were having, and that they found that everything was being shared in a timely manner. So next slide, Katie, please. So one patient, when looking at a couple of the quotes regarding lack of integrated care, one patient commented that after the letter had been sent from the clinical genetics service to the GP to refer them for testing, the GP had simply filed the letter because they didn't know that they actually had to action something. So again, that's a real point of learning for us to take away and support our colleagues in primary healthcare. I say our colleagues, you can see how much I've been involved as an equal partner. And then other people had said that they'd had similar experiences across both primary care and oncology services, where they found that there were notes being shared about them, but they hadn't heard about them. So for everyone here, it's important to understand that healthcare professionals need to also understand the emotional impact that Lynch syndrome has on its patient, I being one of them. So several respondents shared that the first clinician that they spoke to was really crucial, because if that first person didn't have an awareness or an understanding about Lynch syndrome, it felt like it was another emotional barrier for them to overcome. And that just added on to the anxiety and frustration those patients shared. But as well as the negative side of the comments that were given, many patients did say that they felt their primary healthcare teams gave them time to talk about their concerns. And if they didn't have an understanding about what Lynch syndrome was, they actually felt that they went away before the appointment and came to that appointment with the knowledge that they'd researched. And for me, that's fantastic, because it means that was that learning for that professional as well. So overall, really, it should be noted that primary care experiences really range across the region. So next slide, Katie. The recommendations that you can see on the screen regarding lack of integrated care show that talking or taking the step rather to talk to a GP or a healthcare provider is so important, but it is incredibly daunting as a patient to even know how to start that conversation. So to have a GP that understands what Lynch syndrome is fantastic. So we need more of those. It's also around recognising that there'll be multiple factors that affect a person's health decisions, and that everyone needs that personalised approach. So having those central personalised conversations can really help that patient understand what's coming next, look at their family history, preventative measures, but also having conversations with family that Lynch syndrome might be impacting them as well. And it's also a way of making a very emotional process less distressing for the patient going through it. Next slide, please. So moving on to theme 2, experiences with clinical genetic services and hospital care. Experiences showed that many patients felt that they had really good conversations with their genetic counsellors about the process. And many of the respondents said how struck they were with the counsellor's care, time, compassion, understanding, and also the amount of detail that they were able to support the patient with, and with regard to explaining that massive family tree when you're looking back at generations of your family that you may or may not know. And where those patients did have good experiences, it was often because that counsellor took the time to explain things clearly and in language that was understandable. But also it was itemised that having an open door policy, whether the patients took it or not, was really important. So letting those patients know that I am your named contact within the clinical genetics team. If you've got any questions, please come back to me. And I think even if the patients didn't access that, having a named person rather than thinking, who do I go to, was vital, and that extra reassurance. However, that wasn't always the case, and as the same with always the surveys, you hear open door policy with one and a closed door with policy with others. And in some cases, patients felt that there wasn't enough time, that there was a lack of compassion, and in some cases that they'd even been forgotten because they hadn't heard about when they were going to receive an appointment. So even scaffolding the expectations so that patient knows, okay, it's an X week waiting list, would be useful for that patient. So these responses just further show the need for mainstreaming in order to make care more equitable across the region, because as we know, it differs depending where you are geographically. Next slide, please. As you can see from the screen, some patients articulated really clearly what worked well for them. So when they were asked what could be done or what more could have been improved, multiple people said that having that named familiar person or even a Lynch syndrome clinic or space or support group would make that positive difference. And that matches the positive experiences of the people on the flip side who didn't receive that coordinated approach. Next slide, please. So in terms of recommendations, it's really important that the recommendations show that standardising and scaling up this open door approach is vital for patients like us, because it's really useful for us to have a named person so that we know who we can go to, because often admin, knowing who to phone, navigating websites can be just add to the stress of someone's personal experience. And where it is possible, that same named contact should extend across the whole of the family, not just that particular person. Now, we appreciate that's difficult, particularly if you live in different parts of the country, but knowing that there is a one point of contact that even someone could feed those questions into and collect on behalf of a family is really important. And again, the last recommendation shows that there's a vast variation in the quality of this care, and it does create what we all know around creating a healthcare lottery. So this means that one family may experience disjointed care with cascade testing, but another have a really 100% positive experience. So it's how we can close that gap so the lottery is not so vast. Next slide, please. This one for me is really vital, and it's actually why I got involved with talking about Lynch syndrome, because knowledge is most definitely power if it is sought from the right places, not just going to Dr. Google. So anyone's newfound understanding can really help them make sense of themselves, their family history, and also potentially the implications that a Lynch syndrome diagnosis might have for them or their loved ones, even if that's a partner, not necessarily someone who's related by blood. And many people throughout this article, throughout the survey rather, said that they found that this diagnosis was life-saving for them, which is huge. And they said because knowing that they had Lynch syndrome allowed them to take personal measures, but it also allowed them to explore, in line with medical professionals, the use of surveillance through colonoscopies, taking aspirin use, and also potentially looking at risk-reducing surgeries. So empowering patients through support and things such as counselling makes the world of difference in terms of that action, in terms of early detection and those clear process steps for patients to follow. And as I said, if you involve patients and they feel part of the process, they feel that they can contribute to their own well-being as an equal partner rather than something being done to them. And it will hopefully make them more confident in managing their future health too. But these benefits in terms of knowledge is power is really important for families and friends too, because some respondents said that they felt reassured that they were able to talk about and begin the conversation regarding testing in having those conversations with relatives, because they knew what they were talking about and it helped them support their loved ones going through that process as well. Next slide, please. So despite these positives, many people also expressed regret about not knowing their diagnosis sooner or at all, believing it could have significantly changed the course of their illness or an illness of a loved one. So some patients reported that having a family history indicative of Lynch syndrome, but they didn't actually know that Lynch was a thing or that it existed. So it really highlights the greater need for everyone, not just professionals, but everyone to really shout about what Lynch syndrome is so that people have an awareness, because that will reinforce the importance of educating patients and professionals, but also reinforce the message around screening and early detection. And other patients talked clearly about the lack of appropriate information available to them. So it again reinforces the message, and I'm sure this isn't particular just to Lynch, across the whole of the NHS, that clear, accurate, trusted, consistent, readable material is essential, whether that be in printed form, whether that be online, whether that be videos. So the survey highlighted the need to improve that information around screening and the surveillance pathways, even things such as preventative measures, how to discuss the condition with relatives, and how it might affect interpersonal relationships, particularly with regard to family planning. So with this in mind, next slide, please. The recommendations are here on screen. So targeted and accessible support and information for those with a family history of relevant cancers is also required because it underscores the importance of that early screening and how it can change the course of diagnosis. So promoting trusted sources for information will help improve understanding, but also prevent misinformation, either within a family or being spread wider afield. And it will also ensure that information is linked specifically to England, as although there is some learning that can be had internationally, our approach in the UK is very different from someone maybe in America or Australia. So knowing who is a good person to go to, even in terms of expectations around the process, is useful. So one of the recommendations around is looking at that access to support that is on a very everyday level, whether that be social media, support forums or other groups, whether they online or personal groups for peer support. But that's standardized information that will make it clear for the individual, and their families will really help them in terms of their own health outcomes and mental health. Next slide, please. So moving on to the next theme, shared experiences within families. So within the survey, patients' experiences often shared are often difficult to navigate those conversations with your loved ones, particularly if there isn't a consistent approach because you don't live in the same area. So one might have a positive experience of mainstreaming, one might have a negative experience, and all of that can really impact on a patient's overall experience of living with Lynch syndrome and navigating their way through the system. And again, this further evidences a need for trying to create an equitable service, especially across our region. So as well as having a shared experience of Lynch syndrome testing, people often come from a family where there's historical cases of cancer, and it may be that they didn't know anything about the genetic makeup of those cancers. And it might also be that they are living with cancer themselves or potentially supporting someone going through cancer or even grieving. So the sensitivity within that family and the support that's available through that onward management is really important, because those onward management consequences for family members is often considered a priority. It's not just about me, what about them? So the potential impact upon those family members should really be considered, and I implore all healthcare professionals to think about that when trying to support those patients through that process. A number of patients also said that one of the most difficult aspects of the screening process was gathering information regarding their family history, particularly if they weren't connected anymore or they were disconnected completely. So that again is something that we would encourage professionals to be really mindful of when they are looking into the family history. So the report is great. When you get it, turn to page 29, write that down, to have a look at ways to mitigate that situation, because that is a minefield to navigate. Next slide, please. So again, in terms of those recommendations, many patients talked about being thankful that their cancer had been diagnosed at an early stage, or that they'd even been diagnosed with Lynch syndrome without the cancer diagnosis, and that they felt that their Lynch syndrome diagnosis would potentially help save other family members. So these quotes on the screen alone demonstrate that the requirement for additional psychological support and resources in families and relationships should definitely be considered when you're thinking about ways in which to improve. Next slide, please. So in terms of those recommendations, new processes around cascade testing should be considered to improve that support and provide information for the patient and their families. And that as part of a person-centred care delivery, it should be considered that a patient's fears, the decisions and the questions they're asking may be influenced by their loved ones and their family members. So as such, discussions such as the family history, even when it might not be deemed clinically necessary, may be really beneficial moving forward. Next slide, please. So looking at our next theme, psychological and emotional support. So this is really, really key. It's imperative to recognise that this multifaceted approach, for this multifaceted experience that patients go through, will not be the same for every patient you deal with. So for instance, patients could be dealing with cancer treatment simultaneously with discovering that they've got an inherited condition. it might be that they're also battling concerns that they've passed the genetic condition on to their children. You might find that others have experienced loss in their family, which might have been caused by Lynch syndrome, but they just don't know. We just don't know unless we open up those conversations with those patients. So patients talked about the long wait for results and appointments, and that they found that in terms of the limbo land and the loneliness or the anxiety that it brought, that was a real concern for many. So it's not just about the appointment, it's finding ways to support those people with that gap between the first meeting and then some dates and appointments following up. So by having a dedicated point of contact for all questions and queries, some patients suggested that this might alleviate some of the pressures on the NHS as well, because we know how stretched the NHS is. And they thought that maybe by having that sort of one-stop shop where they're sending people to the right person, it might also save other professionals time because people are being sent to the right place. And also with regards to this, a lot of patients were talking about the need for a strong psychological and support network around them. And there's to try and help with a bit of that heavy lifting that a diagnosis may or may not bring. Next slide, please. So the lack of psychological support, particularly at the beginning of the process, was highlighted by patients. So this support is also necessary, I should say, post-diagnosis, because patients will experience a huge range of emotions, including sadness, anger, worry, anxiety, guilt, which came up a lot, and possibly relief, depending on the nature of the result and their view about how it will support them. So suggestions included appropriate signposting to information and emotional support services, things such as a dedicated helpline, annual follow-up calls, consultations with trained mental health professionals. But also patients were saying that they were looking for support that might fit their needs at different times. So it could be that online network that does exist. So again, it's about you knowing what's out there and who best to point your patients in the direction of. So the variety of feedback and experiences evidences the need for a range of varied support to meet a multitude of different needs. One size does definitely not fit all, and I appreciate how difficult that is if you're a professional sitting here, but use your patients to help you with that. Next slide, please. So in terms of recommendations, suggestions include updating patients about expected waiting times, information to read during this waiting period, or even creating that helpline to help patients feel they're not alone, or as if they've fallen through the system, it might help them to know they can phone someone to check where they are. To look at processes being put in place to refer patients for further psychological support, which offer a range of flexible options. And that all patients should be given information about Lynch syndrome UK, the online support forums, Macmillan, informal webinars and patient information days, which will offer them free channel for peer support. Next slide, please. So our final theme is around providing an inclusive and accessible experience of patients. And as you all know, this is essential to delivering compassionate and personalised care for the diverse range of people that you will come into contact with. And that's not just across genetic and oncology services, that's across the NHS. And one person commented on the approach of the genetic counsellor being vital to even opening up a conversation where they felt safe. So people will all react differently to a diagnosis and will have varied expectations of people within the genetic service or even primary healthcare. And another key aspect of providing a service that's open to all is ensuring gender inclusivity and respecting patients' individual identities, as you will see on the next slide. So this person clearly reflected, sorry, Katie, next slide, please. This person clearly reflected that it's important to ensure that clinicians are aware of symbols and the terminology that are used to identify patients. They highlighted that a similar experience could be incredibly different for someone who might not be so open about their trans history. So knowing that individual is so important. Next slide, please. So just to reinforce that training is being recommended to be given to all clinicians about gender inclusivity and how to ensure that patients feel welcomed and respected within any NHS service. That's vital. Next slide, please. So this report that has been beautifully created by the GMSA has revealed that a patient's experience is not only based on their own personal journey through screening, but it's heavily based on that on their family members. So I, here on behalf of the South East Genomic Medicine Service Alliance, as a patient, would urge all our partners here today to continue to read the report when it comes out and to review the recommendations and continue to work towards improving and providing a more equitable service for everyone who is screened with Lynch syndrome. Thank you.
Thank you, Emma. So Steph, we'll move on to you now.
Thanks, Demetra, and thanks, Emma, and thanks to everyone for inviting me to join you today. And I just wanted to share our experience of working with the South East GMSA and just go through how we're going to use patient-reported experiences of the Lynch pathway to develop some improvement opportunities amongst our local services. Just for a little bit of background, we cover a very large healthcare system, and sometimes when you're in that big healthcare system, it can be really difficult to know how to actually get things done. It can feel quite complicated at times. So we spent an awful lot of time initially just working across genetics to really understand who does what and how we can work together and agree some joint priorities. And I think that has been probably the biggest key to our success of delivering some really powerful joint projects. We've now got a really well-established genetic stakeholder group that operates across the Cancer Alliance footprint, and GMSA are regular attendees at trust boards and system boards and a variety of other meetings, so we work quite closely together. I've just included in this page a bit of a snapshot of some of the work that we've done together specifically on Lynch, and hopefully these resources go some way to addressing some of the recommendations that you've just gone through, Emma, that the patient experience survey showed and highlighted. So we've worked together to develop local pathway guidance and supported the establishment of testing and mainstreaming pathways, hopefully to reduce variation and improve access. We're improving awareness amongst health professionals through a joint Lynch working group and a joined up communications plan. And recently, back in kind of November time last year, we ran a series of primary care education webinars. And we've also developed a centralised resource hub to ensure that health professionals have got access to information and training resources so that both staff and patients have increased understanding of the pathway and more confidence. Next slide, please. So learning from lived experiences of patients is a real central focus of our Cancer Alliance, and we're really delighted when the GMSA asked us to join them in developing the design and delivery of the Lynch Experience Survey. We're not really ones to reinvent the wheel, so we were drawing on previous experience, and we're really proud of our health and wellbeing project. So I just wanted to share this with you as a bit of a flavour of the type of work that we're going to be doing for Lynch. So like with the Lynch survey, the resources that were created here are based on themes identified through the Cancer Patient Experience Survey and the Quality of Life surveys. And we created a set of videos that were based on the kind of top 5 needs that patients reported. And these were co-designed with both patients and health professionals. We also created a resource hub, and patients are signposted to this information in a variety of different ways. We've got posters in waiting rooms with QR codes that we've built it into key worker conversations. And we also partnered with Cancer Care Map to generate a directory of local support services. So if you haven't experienced Cancer Care Map, I recommend that you follow the link and click through. It's an amazing resource. And we had really great engagement and feedback from these resources. So when we were thinking about the work we wanted to do with Lynch, this was very much a framework in the back of our minds. Next slide, please, Katie. So today, our focus has really been on educating and raising awareness amongst health professionals, but now we are switching towards what we can do for our patients. So we've teamed up with the GMSA and with Guy's Cancer Academy to co-design some like a patient-facing education module, and this will be a combination of videos, but also can click-through learning material. The topics are based on the findings that were identified through the survey. We're still agreeing the final content, but some of the themes that we want to cover are an introduction to Lynch, so what it is and why it matters, understanding the genetic testing, so how it works, what to expect, how to prepare for your Lynch test, how to prepare for receiving those results. Managing your diagnosis, and this would include different management strategies, and it's really about empowering our patients. Implications for family members, and Emma's just spoken so eloquently about why this is so important. And so having that, how to have that conversation with your loved ones. Emotional support, so thinking about different coping strategies. And again, as Emma mentioned, living with Lynch, so those practical day-to-day top tips that will help you and help family members. The other piece of work that we're doing is to ensure that all of our information is accessible and inclusive. So we are currently working with a translation service to get information developed into our top 10 languages and in easy read format. Once all of these resources are finished, we are very happy to share them with whoever would like access to them. Again, it's a pinch with pride. So I will just stop there, and I just want to take a moment to thank everyone that supported the survey, those that developed it, but also those that responded, because we really can't do any of this without your voices. So thank you.
Thank you, Steph. So I think so just to say that the report is live and we will share it with everyone. And after the report was finalized, we shared it with all the people that contributed, which I think there were more than 120 people that were screened for Lynch syndrome. And these are some of the things, some of the comments we received after they had seen the final result. So it's really good to see that, the report reflected what they wanted to tell us. I think there is a question. I saw a raised hand. I don't see it anymore. We would be very grateful if you could use that QR code to tell us if you thought that was useful. As I said, we will share all the material. I'm just looking at the comments, and there is a comment to feedback to NHS England that the test directors don't work well for Lynch. Yes, so yes, there is a lot to take back from this report, and I think we've done the initial steps, so we have improved testing, but now, as we've heard, it's about improving further the experience, and there are some clear themes. And, some of the things we have already been doing, so we did a GP session with Surrey and Sussex, and very grateful to Steph for supporting that. So, but it's really good to hear that we are in the right track and doing what patients have been asking. There are a lot of more things that we have to build. Steph, you haven't mentioned, but I think whatever we create, we said that it will be available for everyone, and we won't just keep it for the Surrey and Sussex, but it will be available for everyone to access. So I'll just go. I don't know if there are any questions, but I can look at the chat. So I think a patient group next in a few weeks to get feedback. Yes, that would be really helpful to get feedback from other patient groups. That would be great. Stephen wrote, there are many other genetic factors that can increase individual risk to colorectal cancer other than Lynch. Will these be added to the pathway? Yes, that's a fair point. So, this project is on Lynch syndrome, but clearly in the last few years, I think we have learned a lot about genetic predisposition. So there is ongoing work on genetic predisposition in general. There is a question from Agyar.
Zian, I think.
Yeah, I'm just working with obviously in the Southeast London Cancer Alliance, but also with Kathy in the background to make sure that all our patient information leaflets kind of line up. So if we've got a basic version of the easy read and we're going to take it to a patient focused panel just to kind of expedite the position, because we know how long comms takes and all these things. So always happy to share. But I know Kathy said that once all your resources are available, with the translated documents, to try and line up everything, because patients are smart these days. They Google and, they're going to latch on to any different source. So it'd be nice to just have, a more rounded approach.
Absolutely. So there is a question about how this information will be cascaded out to primary care. So as I said, we've already done some sessions for GPs, and as the Southeast GMSA, we will continue to support GPs on this. There is also a discussion nationally about GP coding. Essentially, what that means is that for all genetic predisposition conditions, that now there is an available code. So when the GP looks at someone's records, for example, they have high blood pressure, but also if they have Lynch syndrome, this is also added under the active diagnosis. So there is ongoing work on this nationally to ensure that these genetic conditions are very clearly visible for GPs, that to remind them that if if you see, someone has Lynch syndrome and they come with some symptoms that may be suspicious, that they will refer them urgently for further investigation. So there is ongoing work on this. There is a comment, my consultant still uses HNPCC, so that is a different term. I think the term that we currently use is Lynch, and I think this is the code for the GPs that have been suggested. And some very nice comments. Thank you all for your positive comments. We're very, very grateful. I don't know if there are any other questions. Okay, so Adam.
Thanks. I just want to comment really as a service lead for a genetic service. I think one of the important things about this work is that it makes quite difficult reading for someone in my position and raises some genuine questions about some aspects of the quality of the service we deliver, particularly around timeliness and about ongoing support. And I think that's incredibly useful for us to look at how we configure our services. But also I think it's useful to go back to NHS England, and I think most people in clinical genetic services feel that coordinating care for conditions such as Lynch syndrome is a really important part of our role, and that this is going to become more important as we identify more and more people. So that really needs to be reflected in the commissioning environment and the staffing and so on. So I think it has been quite difficult to look at, but it's given us some really key things to work on. It's someone who's been involved in this for a few years now. We've started out trying just to get the diagnostic test to patients at the point of their cancer diagnosis, and we feel that was quite successful. So we obviously focused on the positives, but what I really take away from it is the group now, and to to recognise a whole change in awareness of Lynch syndrome is really great, and to hear Steph talk so eloquently about something that I don't think she knew too much about Lynch syndrome like 3 years ago. So that's absolutely fabulous. And Emma's participation as well has been extraordinary, very committed to helping us, and that's been really useful. So thank you, everyone.
Thank you, Adam. I'm just looking at some of the other comments. We have patients ringing bowel cancer screening and say they didn't realize they had Lynch. Yes, that is something, you know, we really need to work on. Kevin, yes, we're going to publish this. How does this link with the Lynch syndrome app? So I think there are a lot of people that are developing tools, and one of the things that we really need to do as a group is to gather all that useful information, useful resources, applications, and make sure that patients can access them quickly. And yes, I think we will definitely need the help from all the charities to make sure that all these resources are advertised and people can access them easily. I hope I haven't missed any of the comments.
You've just got one, Dimitra, from Lucy that says, how does this link in with Professor Julian Barwell's work on a Lynch syndrome app at the University of Leicester?
Yeah, so I don't know this particular app, but I know that there are different apps out there. So I think, as I said, it's really important that everything that has been developed and is useful, that we ensure that patients have easy access to it. Great. So we have a few seconds left. So I just want to thank everyone for being here. It has been really amazing to see so many people joining, and thank you for all your kind comments. I want to say thank you to the GMSA team and everyone that has contributed to this work. And Emma, we really couldn't have done this without you. So we can't thank you enough. We have learned so much from you, and you know, it has been fantastic working with you, and I hope we'll continue to do more things for people with Lynch and beyond Lynch. Thank you all.